Welcome to NephroTube Nephrology Online Lectures. In this lecture, we will talk about the diagnosis and the management of chronic kidney disease, mineral bone disorder. The PowerPoint of this lecture and all other lectures and other lectures are available at nephrotube.com. Recorded videos are available on our YouTube channel, NephroTube. Please join our Facebook group for daily MCQs and cases, like our Facebook page, and follow our Twitter account. We discussed before regarding chronic kidney disease, the definition, classification, cause and diagnosis, pathogenesis, progression, and complication of CKD, and we discussed anemia on 2 lectures. Now we will discuss CKD-MBD in only 1 lecture. I will collect all the data about CKD-MBD in this video. As we all know that the definition of mineral and bone disorder that is related to chronic kidney disease is a combination of 3 important parameters. Mineral and bone disorder will involve laboratory abnormalities in the patient, bone abnormalities, and vascular calcification. These are the 3 main components of mineral and bone disorder. Let's start by laboratory abnormalities. Back to basics before going through what is happening in CKD. What is the normal physiology of the PTH, vitamin D, calcium, phosphorus axis? Normally, we know that the parathyroid glands release PTH. PTH acts on the bone, which will cause increased release of calcium and phosphate from the bone to the circulation. Normally, PTH stimulates the kidney to increase calcium reabsorption and increase phosphate excretion. So, the end result of the action of PTH collectively on the bone and the kidney is to increase the serum calcium and decrease serum phosphate because it's phosphatoric effect and excretion of phosphate in urine. So PTH action is to increase serum calcium and decrease serum phosphate. So what stimulates the release of more PTH? Low serum calcium and the high serum phosphate will stimulate PTH release, and vice versa also. Because PTH increase its action normally increase calcium and decrease phosphate. So if there is low serum calcium or high serum phosphate, this will stimulate PTH to be released. What about vitamin D? In short, vitamin D inactive forms will be converted by liver to 25-OH vitamin D under the action of alpha-1 hydroxylase in the kidney, which is stimulated by the PTH. The inactive form of vitamin D, calcidol, will be converted into calcitrol, which is 125 vitamin D, and it is the active form of vitamin D, which will act on gastrointestinal system to increase both calcium and phosphate reabsorption. So the end result, active vitamin D will cause increase in serum calcium and phosphate. So what stimulates the activation of more vitamin D is the hypocalcemia and the hypophosphatemia. Okay. What happens in chronic kidney disease? First of all, the patient has renal failure, so there is no activity of alpha-1 hydroxylase enzyme, so there will be no activation of vitamin D, so the patient has low vitamin D level and low calcium and phosphate absorption from the intestine. Second, because the kidney is non-functioning well, the reabsorption of calcium may be defective, which will cause hypocalcemia in this patient, and also the excretion of phosphate will be defective, which will cause hyperphosphatemia in our patients. So the end result of these patients, chronic kidney disease patients, will be decrease in vitamin D, decrease in serum calcium, and increase in serum phosphate. And as we said before, that the decrease in serum calcium and the increase in serum phosphate will stimulate PTH release, which will cause in these patients secondary hyperparathyroidism. With high PTH level, it will act more on bone, causing bone disease in the form of bone pain, maybe fractures, maybe more bone marrow fibrosis and erythropoietin resistance. Okay, if our patient didn't treated from hypocalcemia and hyperphosphatemia, and they persist, this will cause more stimulation for a longer time for the parathyroid gland, which will cause parathyroid adenoma, which will eventually cause very high level of PTH, and this is called tertiary hyperparathyroidism, which will affect the bone more, and finally it will increase serum phosphate and calcium due to increased osteoclastic activity of the bone. So we have now what is called secondary hyperparathyroidism in our patients, and this is a classical. You will find high PTH, low calcium, and high phosphorus. This is in the untreated patients. And tertiary hyperparathyroidism due to persistent untreated hypocalcemia and hyperphosphatemia. In this patient, you will find very high PTH level, high calcium level, and phosphate level. Why there is high calcium level? This is because increased osteoclastic activity of the bone. And in both, you will find high bone-specific alkaline phosphatase, which indicates hyperactivity of the bone cells. What about what is called FGF23, fibroblast growth factor 23, and what is its relation to the CKD-MBD? Back to basics, what is normally happened in our body? Increased phosphorus in the serum stimulates some bone-specific cells, which will cause release of fibroblast growth factor 23. Fibroblast growth factor 23, normally it tries to increase phosphate excretion by the kidneys. So it has a phosphatiuric effect. But in CKD patients, as there is no excretion of phosphate, so FGF23 action is abolished, and the patient will have maintained the high serum phosphate level, which will stimulate more release of FGF23, and this patient will have persistent very high level of FGF23. And the evidence found that the higher the FGF23, the strongest independent predictor of mortality in chronic kidney disease patients. So high FGF23 is a strong independent predictor for mortality in CKD patients. So these are the laboratory abnormalities, which is one of the components of mineral and bone disorders in chronic kidney disease patients. What about bone abnormalities? We all know the classic classification of the bone depends on the turnover of the bone, mineralization of the bone, and volume of the bone. According to the turnover of the bone, the abnormalities or the shape of the bone or the turnover of the bone is classified into normal turnover, high turnover, or low turnover. The turnover means or defined as the balance between the activity of the osteoclast and osteoblast in the bone. In CKD patients, you may found normal bone formation or low turnover bone disease or high turnover bone disease. You may found normal bone formation in our patients if the PTH of the patient is between 150 to 300. Although these numbers have some modification that I will mention now that was published in the recent KDIGO guidelines. But actually, between 150 and 300 picogram per ml PTH, we found normal bone formation in our patients. Actually, this is higher than the normal PTH level. We all know that that we need the PTH level in CKD patients to be higher than normal. And I will say later in this lecture that it is accepted that the PTH may be 3 times to 9 times the normal level. Why we need higher PTH? This is what is called the reverse epidemiology, and we mentioned it before in previous lectures. Because the normal PTH level in CKD patients will be resisted by uremic toxins. For PTH in CKD patients to do its effect, we need higher PTH level to overcome the bone resistance that is developed due to uremic toxins. So to maintain normal bone turnover, normal activity of osteoclast or near normal activity of osteoclast and osteoblast, we need the PTH to be around between 150 and 300. If the PTH is lower than 150, so the turnover of the bone will be low, with more activity or decreased activity of the bone cells. If PTH is more 300, so we have what is called high turnover bone disease, which was classically called ostitis fibrosa cystica. And not surprising that we may find mixed lesion in one patient. And this is the main dilemma and our main problem in the management of CKD patients. Let's start by the first part. What if the patient has high PTH level, more than 300 picogram per milli? This will lead to increased bone resorption and increased numbers of osteoclasts and osteoblasts and more activity and turnover of the bone. So you will find this shape in X-rays. You will find erosion in the bones, and you will find these empty cysts in the bone, what's called ostitis fibrosa cystica, due to high turnover and the high activity of the bone. This is another shape in the bone, empty bone, black bone on the X-ray, cystic formation due to high activity of the bone cells. You may find it in the skull in the shape of what is called salt and pepper appearance. You will find areas with white and areas with black dots. And you may find in the spine the sign which is called the Ruger-Jersey spine. White band followed by black band, white band followed by black band. Ruger-Jersey was an old football team. Their uniform was in the form of lines, white and black lines. Looks like this vertebral column. This is one of my cases. You will find here a collapse between these two cervical vertebrae due to hyperdynamic bone disease, and in the MRI you also find the erosion of the bone due to hyperactive turnover bone disease. So clinically you will find in this patient bone fracture, bone pain and discomfort, and maybe metastatic calcification due to the release of calcium from the bone secondary to hyperactivity of the bone cells. So now what about what is called low turnover bone disease or adynamic bone disease? In this patient, the activity of the gland is low and the activity of bone cells will be low. There will be low or absent bone formation. What is called adynamic bone disease. In this patient, what is the cause? What makes the PTH low in CKD patients? The main pathophysiology that we explained at the beginning of this lecture show that the PTH must be high because our CKD patients have low calcium and high phosphorus. So what are the possibilities that will make a CKD patient to have a low PTH? First of all, it was attributed to aluminum toxicity. That is rare nowadays, but it was very common in the past. And the aluminum toxicity was mainly from the water, especially water treatment unit in hemodialysis patients. So aluminum toxicity suppress bone and suppress PTH. But the most common nowadays that may cause suppression of PTH and adynamic bone disease is an iatrogenic cause, which is over-treatment of hyperparathyroidism. The treatment that we will mention later, that you're trying to manage the secondary hyperparathyroidism in CKD patients, but you over-treated this patient and you over-suppressed the parathyroid gland, causing what is called a dynamic bone disease. In this patient, what are the laboratory markers? We all know that we mentioned in secondary hyperparathyroidism and in tertiary hyperparathyroidism. So what is the difference? What we will find as a laboratory changes in this patient? Yes, we will find low PTH and we will find low alkaline phosphatase because the bone marrow activity will be low. Sorry, because the bone cells activity will be low, but we will find high calcium and high phosphorus in the serum. Why? Because low PTH will decrease the activity of the bone cells. So the uptake of calcium and phosphorus from the serum will be decreased, which will cause high calcium and high phosphorus in the blood due to decreased reuptake of the bone for these molecules, which will cause high incidence of tissue calcification because excess calcium in the blood will be deposited in extraskeletal compartments. What is the target of PTH in our patients? It is accepted that PTH level in our patients to be between 2 to 9 times the upper normal level. But we have to put an important point in our mind. We will not depend in the management of our patients on a single number of PTH. We depend mainly on the trend. What is meant by trend? The propagation of the PTH level. What is the PTH level of this patient in this lab test in comparison to previous lab results? For example, if you have a patient with a PTH level of 250 and the next with controlled calcium and controlled phosphorus and controlled bone manifestations. After 3 months, his PTH is 260. After other 3 months, his PTH is 255, and so on. So the trend of this patient PTH is constant or near constant. But if you have a patient, say, with a PTH of 250, and the next PTH after 3 months is 300, and the next after 3 months is 450, so the trend is increasing. So here there is a problem. So you have to reconsider modification of the management of the drugs of this patient. What is the frequency to monitor lab parameters in our patients? As is recommended by CKD guideline 2017, in patients with CKD stage 3 to 5, it is important to monitor serum calcium, phosphate, and PTH. On the presence, your monitoring frequency depends on the presence and the magnitude of the problem and the rate of progression of CKD. But reasonably, the monitoring intervals are in stage 3, serum calcium and phosphate monitor every 6 to 12 months. For PTH, monitor on baseline level and CKD progression. So you have to monitor it only on baseline, and if the CKD is progressed, you have to monitor it again. CKD stage 4, serum calcium and phosphate will be monitored at higher frequencies than stage 3. They will be monitored every 3 to 6 months, and for PTH, every 6 to 12 months. For CKD5, including those who are on dialysis, for serum calcium and phosphate, monitor every 1 to 3 months. For PTH, every 3 to 6 months. Regarding alkaline phosphatase, start to monitor it at stage 4 to 5, every 12 months, or more frequently. Regarding the word more frequently, will be applied to all lab parameters. You may need to monitor all lab parameters more frequently if you are changing the medication of the patients and you try to follow up the effect of your changes. One of the most important points is that our patients may have other bone diseases rather than the classic renal osteodystrophy. They may have osteomalacia, they may have osteoporosis, many other bone abnormalities, and this is one of the main problems that we are facing in our patients. And for this, I'm recommending for you one of our lectures of nephrotube.com, which is called Osteoporosis in CKD, the Challenge. You will find the PowerPoint on nephrotube.com on the sector of CKD. In this lecture, I talk in details about how to diagnose osteoporosis in CKD and how to manage. We all know that there is an update for the diagnosis and the management of osteoporosis in CKD. In the new KDIGO guidelines 2017, they recommended or suggested the use of DEXA scan in CKD patients, and that you may manage the patient for osteoporosis without bone biopsy under some circumstances. All these details are found in this lecture on NephroTube. Back to our main lecture. We discussed the laboratory abnormalities and the bone abnormalities. What about vascular and soft tissue calcification? With the disturbance of calcium and phosphate in our patients, you will find high calcium phosphate product, which will cause calcium and phosphate deposition in different extraskeletal parts, as in vessels, articular, extra-articular soft tissue, and maybe under the skin, which may cause pruritus. This is an example for the calcification of the vessels and soft tissues. Here is a blood vessel, calcified blood vessel, calcification in the lung, in the shoulder, and it is important for us to know the targets for the management of CKD-MBD. Usually we trying regarding serum calcium and phosphorus to maintain them within the normal range. And regarding the target of PTH, I said that in patients, especially who are on hemodialysis, the range may be accepted from 2 to 9 times the normal, depending on trend. Regarding patients who are not on dialysis, the PTH level optimally is not known. What about the management? The drugs that I can use. We have main 3 categories: phosphate binders, and at the same time the phosphate binders are calcium supplements. We have vitamin D analogs or vitamin D like drugs and cinacalcet. What about phosphate binders? First of all, the old traditional phosphate binder was aluminium, but as we know that it may cause high risk of aluminium toxicity on our patients, so it is better to be avoided. Or if you will use it, and I don't recommend or suggest it, but if you will use it, you have to use it for a very, very short time, 1 to 2 weeks. Calcium salt based, they are phosphate binders. Their main component is calcium. We have calcium acetate and the calcium carbonate. You can use both of them as a phosphate binder or as a calcium supplement. If you want to use calcium salt based binders as a phosphate binder, you have to make your patient to take them within the meal to bind the phosphate in the meal. If you want to use calcium salt based drugs as a calcium supplement, you have to give them to your patient on empty stomach. So your patient has to take them after the meal by 1 to 2 hours. And it is important to mention that calcium acetate may be of a higher phosphate binding effect than calcium carbonate. The next are non-calcium containing phosphate binders, sevelamer hydrochloride and sevelamer carbonate, and the lanthanum carbonate. They are effective also. They are not containing calcium, so they can't be used as a calcium supplements, but can be used as a phosphate binders. So they are taken within the meal. The main problem that they are very expensive, and one of the most important point that cevidomir hydrochloride may cause metabolic acidosis because it contains HCl, so it's better to be used for patients only on hemodialysis. But in CKD, it may cause metabolic acidosis in this patient. So which is better to be used? The calcium containing phosphate binders or the non-calcium containing phosphate binders? Many studies try to compare between them, but actually at the end, there is no major difference between them regarding mortality and the controlling of the CKD-MBD in our patients. But it may be more wise to avoid calcium phosphate binders in patients with the evidence of extra skeletal calcifications. And we may discover this by finding calcification on cardiac valves, by finding calcification in abdominal aorta or different vessels by even only X-ray of the abdomen. So it's better to avoid calcium phosphate binders in patients with evidence of calcification, and usually in all the patients and diabetic patients. All the patients and diabetic patients. Okay. What about vitamin D analogs? These are some forms of active vitamin D. One of the most famous is the alpha calcidol, which is the 1-OH vitamin D. It requires activation in the liver to be changed to 125. So here we reverse the normal pathway of the vitamin D. Normally in our body, the 25 vitamin D is formed first in the liver, then 125 by the kidney. In this patient, because the kidney is not active and the formation of the 1-OH vitamin D is not present, so we give 1-alpha hydroxylase for our patients, which will be converted by the liver to 125. And it will cause increased calcium and phosphate level in our patients. So it is important to know that don't use alpha calcidol or any other forms that have the same action in patients who have hyperphosphatemia. Use a vitamin D analogs. The patient phosphate must be controlled within normal level, or you will have hyperphosphatemia in your patients. Other vitamin D analogs or like drugs, the paricalcitol and calcitriol, they are not available in all countries, and they are also very expensive. They are mainly biologically active vitamin D receptor agonists. They activate the vitamin D receptors directly. So they will cause both increase in serum calcium and phosphate level too. So they must be avoided in patients who have hyperphosphatemia. What about cinacalcet? Cinacalcet is a drug that is used mainly in patients with tertiary hyperparathyroidism. In patients with very high PTH level, high calcium and high phosphate level. Cinacalcet acts on the parathyroid gland cells. This is a parathyroid gland cell. On parathyroid gland cell, you will find what is called calcium sensing receptor. The cinacalcet increases the sensitivity of calcium sensing receptor to calcium, which will cause negative feedback and decrease PTH level. So the cinacalcet increases the sensitivity of the parathyroid gland to serum calcium, which will help to decrease the PTH level. Cinacalcet is important to be used in patients who have persistent hyperparathyroidism, especially in high levels of PTH. And it is important to try to use cinacalcet before the decision of doing a parathyroidectomy to our patients, because it may be effective to decrease the size of the parathyroid gland and the activity of the parathyroid gland. Okay, as we said before, the therapeutic decisions must be based on trends rather than on a single laboratory value. This is very important. And it is reasonable to base the frequency of monitoring on the presence and the magnitude of problems and the rate of progression of CKD, and also to monitor for trends and treatment efficacy and side effects. When parathyroidectomy may be indicated, if there is severe persistent hyperparathyroidism, especially after the trial of cinacalcet, which will be manifested by persistent hyperphosphatemia, persistent hypercalcemia, persistent metastatic calcification, and also if there is a manifestation of muscle defect or motion abnormalities, as in shoulder limitation movement or any other indication that there is a presence of limitation of movement due to calcification of the joints or the muscles. What about native vitamin D? The vitamin D analogs that we mentioned are active forms of vitamin D. What about vitamin D? Native vitamin D, which are the inactive forms of vitamin D. Are our patients in need to be supplied by native vitamin D? The answer is yes. 25 hydroxyvitamin D, calcidiol. It is important to monitor the level of calcidiol in our patients. And if the patient has deficient vitamin D, it is important to replace the patient for a target of more than 30 nanogram of vitamin D25. This is because the native vitamin D has multiple effects away from the effect on calcium and phosphate level. Native vitamin D has a immunomodulatory effect, has an antidepressant effect. There is a little evidence that increase the sensitivity of erythropoietic cells and have many multiple anti-malignant effect. So it has multiple effects that the patient may get benefit from. So the target of vitamin D, native vitamin D, 25 calcidol vitamin D in our patients is to be more than 30 nanogram. If the patient has vitamin D deficiency, you have to load the patient with vitamin D at the start by ergocalciferol or cholecalciferol. You have to give the patient about 2,000 units per month. You can give him weekly a 50,000 dose or 200 dose in a single ampoule over 1 month. And you have to monitor vitamin D every month till you reach the target, which is more than 30 nanogram. Then if you reach the target, you have to give the patient maintenance dose, which is about 40,000 international unit per month. So replacement of vitamin D is very important in our patients. Thank you for your watching and see you in next lectures.